Hello, 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 everybody. Welcome, welcome, welcome. Tonight, it's a special Tuesday night special on Kidney Stories 2. Tonight, the boss is on with us. That's right, Steve Belcher is on with us tonight. So, Steve L Belcher, RN, SMN, MS, is a former dialysis nurse clinician of 33 years and founder/executive director of the Urban Kidney Alliance, a 501c3 grassroots nonprofit organization. He served 3 years in the United States Army in combat arms as a 19D Cavalry Scout. In 1985, he began his career in kidney dialysis at the Austin Diagnostic Clinic in Austin, Texas, as a patient care technician. In 1991, he enrolled in the University District of Columbia Nursing Program in Washington, D.C., where he received his Associates of Art degree in nursing. In 2003, he obtained his Bachelor of Science degree in nursing for the University of Maryland School of Nursing in Baltimore City, Maryland. He currently holds 2 master's degrees, a Master's of Nursing with a specialization in leadership and management, and Masters of Science in Health Education and Promotion, both from Walden University. He also holds a postmaster certificate in a nonprofit management. In 2007, he served as CEO of Kidney Clinic Consultants, and in 2008, he served as CEO of Servire, S-E-R, capital V-I-R-E, a dialysis management company. Steve has worked for numerous dialysis corporations such as Foundation Medical Staffing, DaVita Dialysis, Fresenius Medical Care, and Independent Dialysis Foundation as a clinical charge nurse. He also managed several nursing home dialysis units as a regional nurse manager for Advanced Dialysis Center. In addition to hosting live broadcast shows, he currently is the senior producer with Urban Health Outreach Media, a subsidiary of the Urban Kidney Alliance, and an online kidney disease and health education media broadcasting company. And wow, are we all glad to be with Steve, right? Recent accomplishments: author, what we're going to talk about tonight, published a book, How to Survive Outpatient Hemodialysis, a guide for patients with kidney failure. The United States of America's President Volunteer Service Award, a gold medal honoree, and a recipient of the 2019 AAKP National Social Media Education and Advocacy Award recipient. Tonight, I'll hold it up, put it on the camera. There you go. Tonight, we discuss with Steve his new book, How to Survive Outpatient Hemodialysis, a guide for patients with kidney failure in some detail. I'm in the process of writing a longer review, but I want to give you a brief preview of what to expect. This is a great book. In particular, if you're new to dialysis, this is a terrific book. It really covers the waterfront. It's short, concise, written in easy to understand language, and you can tell it's written by someone who has truly been there. It is a must read for the newbie. Ladies and gentlemen, let's talk to the boss tonight. Steve Belcher is with us.
Hey, Uncle Jim,
Hey.
what's going on?
Hello. How you doing, Steve? Good to see you, buddy.
Thanks a lot.
Listen, did I get everything in your biography correctly when I did the introduction? Did I mess anything up?
I mean, nope. Everything was dead on.
Okay. I just want to say so everybody knows, if you're interested in purchasing Steve's books, I left the links in the notice of the broadcast, so you can find places where to buy it. Our favorite is stevebelcher.com, and who knows, maybe Steve will even sign it for you if you buy it from his website. So, check us out. All right.
But before you start, Uncle Jim, I would like to give my condolences to the family of Shayla McMillan, who unexpectedly lost her life to kidney disease, I believe maybe overnight or this morning, but I found out the news early this morning. So I just want to publicly give our condolence from Urban Health Outreach Media to the family of kidney warrior Shayla McMillan.
Okay, condolences to Shayla and her family and her friends. And we will carry on as kidney warriors as best we can. All right. You are the author of a new book, How to Survive Outpatient Hemodialysis, a guide for patients with kidney failure. Why did you write this book, Steve? What was your motivation to do it?
Well, Jim, to be honest, as you know, we do education shows on Urban Health Outreach Media Network. And so I put in a lot of time when I used to do a lot of the education shows to try to give back to kidney patients who may not know what to look for in the treatment. And so as a result of lack of participation in audience, I decided to put the material in a book, and hopefully that people would look at it for the value at what it was. I felt like when I was doing the shows and a lot of stuff that's in the book I talked about on live and did education shows on it and had a lack of audience. And so I decided that in order to get that message out to kidney warriors around the world that may not know about the shows, I thought that this would be a better way. And also, I had an epiphany to write the book as well. And I was able to do it in 3 weeks.
Oh, wow. That's fast, Steve. Really fast. In your experience, are new dialysis patients sometimes overwhelmed by all of the information, all of the new experiences? They lack info on what to expect?
Absolutely. Throughout my career, there's been many patients that I admitted through the admission process, and a lot of times patients get, once they get discharged from the hospital, they don't have any education. There's a lack of education between the time they're in the hospital and they start outpatient dialysis. So when they come to the dialysis clinic and when they're confronted with a lot of paperwork, that's when it becomes overwhelming to them.
Okay. So if I'm right, true or false, that the audience that you're aiming at here, you're looking at primarily new hemodialysis patients. Is that a fair statement, Steve?
Pretty much, and veteran dialysis patients who may have went through the process and forgot about everything that was told to them in the beginning, if it was told to them. And so what I tried to do was to hit it in two folds. Help patients who are newly diagnosed and patients already on dialysis that, again, may have forgot about the process.
Okay. I know that when I started dialysis, and you know, buddy, I was on dialysis for 4 years myself. I had this very alone feeling, you know, like I was the only one, that there wasn't going to be anybody I could lean on. Could you talk to us about that feeling alone emotion that many new dialysis patients experience?
Absolutely. You know, in my experience of what I've seen, for a lot of patients that get hit out of the dark, that don't know that what happened to them, I mean, it's a new experience. It's like a new normal. And especially if they don't have a support system or family members to be there with them to go through that process, is really hard. But for a lot of patients, especially patients with family members who do have a support system, they still feel alone because they don't know what's going on. All they know is that their kidneys has failed them and they have to start dialysis, whatever form, whatever option that they choose to or they know about. Normally it's outpatient, but even now, more than ever in this age of COVID, where a lot of facilities are not letting family members go back into the clinical treatment area with their loved ones during this time, which a lot of loved ones are used to doing, that may be sitting right next to the chair of their loved one or just being there for comfort measure. So yeah, a lot of patients go through that loneliness because they don't know what to expect when they start dialysis unless their doctor has given them information or they know someone who went through the same process, like a peer member or someone who's on dialysis. And even that, even knowing somebody, you don't get the whole detail because they're just telling you from their experience. They're not giving you from a professional experience, such as what that book tells you.
Right, right. So part of the reason that you wrote the book was to eliminate or lessen the fears of the new patients, to try to give them information so they know what to expect when they go on dialysis.
Yes, I wanted to alleviate that anxiety that many patients experience on that first day because they don't know what to expect once they go into a facility that they never been in before. So what I try to do with this book, if they're able to get it, excuse me, if they're able to get it when they're in the hospital or before they reach kidney dialysis, then hopefully that book would pretty much lessen the load. It's not going to take away all the anxiety that one may experience or face going into dialysis. But what my goal was to hopefully alleviate some of that anxiety, so they know what to expect and how to deal with it once they are confronted with the situation.
Okay. Talk to us a little bit about what chronic kidney failure is and what choices the patient has once this occurs.
Well, for a lot of people that may be watching that's in the kidney dialysis community, they know how this disease occurs, especially if it's from diabetes or hypertension. I can't speak on genetic disorders, but for people who's watching this that don't know anything about kidney disease, it's the 9th leading cause of death in the United States, and it's a slow, insidious disease that occurs over 5 stages. And if it's caught soon enough, particularly in stage 3, it could be halted or even reversed to stage 2, according to preventive nephrologist Dr. David Moskowitz out of Hollywood, Florida. But kidney disease occurs over time. 9 out of 10 Blacks have stage 3 and don't even know it. As I mentioned before, there's 5 stages, and a lot of people don't know that they're at the end stage until it's too late, until they start having a myriad of complications that are associated with chronic kidney failure, such as nausea, vomiting, metallic taste in your mouth, anemia, weakness, and a host of other symptoms that can range from pruritus, which is itchiness, to belching, to uremic flakes coming out of your skin. It just depends on the person and how severe the disease is. But yes, kidney disease is a slow, insidious disease, and the 2 main causes of kidney disease is hypertension and diabetes is the leading cause, and then hypertension comes in second. And then you got your genetic disorders and your other chronic diseases that pretty much associated with kidney disease, like lupus or polycystic kidney disease or any type of medication like NSAIDs that's nephrotoxic or kidney toxic. So it can happen in a lot of ways. And now with the COVID, you have a lot of new cases of chronic kidney failure that's COVID related.
Okay. And in terms of replacing your kidneys, or what the doctors refer to as renal replacement therapy, what you're looking at is hemodialysis, peritoneal dialysis, or a kidney transplant. Those, would you agree those are your basic choices?
Absolutely. I mean, patients, and that's the thing, Uncle Jim, a lot of patients who are hit just out of the blue don't know about these treatment options. And so, like you said, you have hemodialysis, which can be done in center or at home. And you have peritoneal dialysis, which could be CAPD or CCPD or manual exchange. And then you have nocturnal dialysis, which units perform 6 to 8 hours throughout the night. And the goal with dialysis is to feel better. And the longer the treatment, a lot of patients don't like to stay on dialysis for a long time, and I understand that. But they have to understand, if your kidneys work 24/7, hours a day, then you have to think about treatment in that same aspect, where the more treatment you get, the better you feel. And so that's why you see a lot of patients going to outpatient dialysis who run 3 hours and they may only have KT over V or their clearance, which is, KT over V is a measurement of how much urea and waste is removed from the blood. So when you have patients that run 3 hours and they may get a clearance of, say, 1.1 or 1.2, and 1.2 is the national standard. But then you have patients at home that get KT over V's or numbers of 2.0 or higher, and you can see the difference of treatment and how they feel. Their skin is a lot brighter. Everything is a lot better with longer treatment, opposed to when you're going into a clinic for 9 hours a week and you're trying to pull off 3 to 4 hours. Three to 4 liters of fluid in a 3 hour period. That's a lot of stress on your heart. And again, some patients tolerate it and have good clearances and some don't, but scientific and research has shown when patients have a longer treatment, they feel much better and have a much quality of life.
Great. Tell us a little bit how hemodialysis works. How often do you go in to take it? How long are you there? What exactly is it designed to do?
So hemodialysis is designed to where you go either outpatient clinic or you do it at home, where you have an implanted access in your arm, in your leg, or you have a catheter, something similar to this. And what it is, your blood is these lines are connected to the access where you have blood coming out, which is going through the machine and is being cleansed, pretty much being washed with dialysate. The urea, the waste is removed, as well as fluid is removed from the blood. And this is a constant cycle going over 3 to 4 hours time, 3 days a week. However, you do have patients who do start dialysis that still have urinary output, where their physicians may only order them to be on dialysis maybe twice a week. So you do have those type of situations, but the usual process is anywhere from 3 to 4 hours, 3 times a week.
Okay. Let's talk a little bit about the people that are on our renal team when we start dialysis. The nephrologist, the nurse practitioner, the change nurse, staff, social worker, and dietitian. Can you tell us a little bit about what each person does?
Okay, sure. So when you go down the chain, normally the nephrologist or the kidney doctor is usually the medical director of the facility. And so they may have the majority of the patients, or you may have some other doctors that have privileges that may admit their patients to the unit. However, the person is like a corporation. The person in charge of that facility is the medical director or the kidney doctor. And then from there, you have the administrator of the facility that, again, is almost like a CEO as well, but they oversee the operations of the facility and the unit, make sure everything is according to Medicare guidelines and CMS and quality insurance. They just maintain an overall function of the unit. Then you have your social worker who deals with social services. When new patients start, they help them with transportation, getting information from the Kidney Foundation and they need help with money or anything like that. They go over surveys with them. They just help patients in the social service aspect of managing this disease. Then you have your dietitian who overall sees the nutritional aspect of the patient. Then you have the charge nurse. That's what I did, who pretty much runs the unit. You can't open up a dialysis facility unless the charge nurse is there. So the charge nurse is responsible for the technicians and the other nurses that are working on the floor, call the doctor when there are problems, and pretty much handles situations when they arise. Then you have your biomedical technician who fixes the machine, does the water cultures, and handles everything that comes down to the water system and the machines, the PMs, the safety checks. When the machine breaks down, they fix it. And then you have your staff nurse and your technicians who, the staff nurse or the charge nurse, they do the overall assessments when the patient comes in. They'll split up the room, and if you got, say, 30 patients, one nurse has 15, the other has 15, and we do the assessment, listen to their heart and lung sounds, checking for edema in their ankles, assessing them for any other problems that they may have experienced between treatments. And then we also administer the medication. If they get antibiotics, they want Benadryl for itching or Tylenol, or if their blood pressure is high, we may administer clonidine or Procardia. And so then you have the technician who is pretty much the direct caregiver. 99% of the time it's the technician in the outpatient unit that deals with the patient 101. And they're pretty much our eyes and ears for direct problems. So a lot of times patient would talk with the technician because that's the direct care. And so we looking for the technician. If the patient tell them anything that's out of place, we expect to get that information so we can assess it and, address it.
Right. One of the things that you talk about in the book is that a hemodialysis machine is designed to clean the blood, and there's a certain amount of blood outside of the body at a given time. This kind of surprised me. Can you talk about that a little bit, please?
Yeah, I believe it's between 1 and 2 cups of blood is actually outside your body when it's going through that process. And what I mean by outside your body, the moment that it's coming out of that arterial line and it recycles and it goes back to the venous. Once you disconnect from those 2 ports, the total blood that's in that system has been said to be estimated between 1 to 2 cups. I believe it's 2 cups, but that's why I put that that 1 to 2. But don't quote me.
Okay. One of the other things that got my attention was that the book talks about medical complications that can occur during hemodialysis. Can you give us some examples of what kinds of things we're talking about?
Absolutely. And I'm glad you brought that up, Uncle Jim, because that's one thing that a lot of patients aren't aware of. When they start dialysis, they think of it as you go to dialysis, you get your blood clean, and then you leave. But on the flip side of that is that there are complications, like you said, that can occur, such as cramping when you're pulling off too much fluid, hypotension or low blood pressure. And then as a result of low blood pressure, You have a lot of patients that may experience vomiting and nausea, or they may pass out. You may have rapid heartbeat. You can have separations of the dialysis line, far as patient could go on and maybe the technician or nurse didn't tape the needle down all the way, and then say if the patient moved their arm a certain way, or if the lines are hanging by the chair and they caught on something and the patient doesn't realize that, and they move their arm suddenly and the needle comes out. I've seen plenty of situations where the needle came out of the venous site or the arterial, and we had to stop the treatment. Of course, you have to clamp the lines to prevent the patient from bleeding out. So then you have complications like machine complications that could break down while the patient's on, and you got to return the blood, or some units, they don't even return the blood. They just take everything and move it to another machine with the blood still in the system, and put it right there on the patient, and move the chair over to kind of decrease the time. But at the same time, that's not a safe practice. Okay. But yeah, there's many complications. Cardiac arrest is one that we nurses kind of in the back of our mind always look out for, because it can come
out of the blue, right? I mean, my experience with that, I lost 4 clinic mates when I was on dialysis, and it seemed to come so very fast. So I can understand why you guys have to be careful with us as patients. Talk to us a little bit about what adequate dialysis means. In other words, how do we know we're getting enough dialysis? This is one of your big things, this stuff you always post about. How do we know if we're getting adequate dialysis? What scientific measurements do we look at to determine if we're getting adequate dialysis?
Okay, so we talked about that a little earlier about the KT over V, and that's a measurement of how much waste in urea is being removed out of the blood. So adequate dialysis, I mean, that you want to make sure your blood flow rate is where it's supposed to be. If it's supposed to be at 400 milliliters per minute, that's where it should be at, not 350, unless something's going on with your access. You want to make sure your access is working correctly. You just want to make sure you run your whole treatment time, and you just want to make sure your whole prescription for dialysis that the doctor ordered is being followed. And again, it also have to look at your access as well, especially if you have a catheter. You want to make sure that's running properly, because if your catheter is not working right, then you're not going to get adequate dialysis. If your arm, if you got stenosis, where narrowing of your veins, and you're not getting a good treatment, you're not going to get a good clearance of blood. And so all this works hand in hand with the artificial kidney, the access, the blood flow rate, your dialysate flow rate. All that works together to make sure you get adequate treatment. Your treatment time, person coming to treatment 3 days a week and running their whole treatment time, and just being mindful also of your dietary intake when it comes to potassium, phosphorus, calcium, potassium, your albumin. All this works hand in hand, and and again, that's why I put that in the book, because a lot of patients aren't aware that these things work together in the system. And so if one is off, then it can affect your numbers. So if your catheter is not working right, say for instance, only one side of the catheter works, because sometimes these get blocked because of the small holes up there, so they get occluded. So if only one side is working right, and you know, you're using the side that's not working, that you can't get proper blood flow as the return, and then when you try to turn the blood flow rate, the blood pump up to a speed that the doctor ordered, say 350 to 400, and the machine keeps going off every 5 or 10 minutes, it's stopping, going off. That means you have improper functioning access, and you're not getting a proper cleaning. Your machine keeps stopping, and you got to keep pressing the button, and the technician is coming and fooling with the access, or adjusting the needle. Then you're not getting a proper cleaning. And so that's why all this is important, to look at these different functions that create this system of making sure that you get adequate treatment.
Okay. One of the other concerns that you write about in the book is preventing infection to the patient. Can you talk to us about the steps that are taking to help prevent infection to the dialysis patients?
Sure. Well, the steps that's supposed to be taken when you're dealing with a dialysis patient on an outpatient basis is you're supposed to don or put on your PPE, or personal protective equipment, as is formally called. And this entails goggles or a face shield, a mask, and a gown or a lab coat. And so when you're performing the process of hemodialysis, when you wear these garments, the PPE is supposed to protect you and the patient from blood splatter or anything that may happen throughout the process, to get in, prevent from getting into your mucous membranes. Also, when you're going through this process, you're supposed to wash your hands for at least 20 seconds, according to the CDC. And you can use hand gel, but basic hand washing has been found to reduce the spread of infection. And so when we do this procedure, hooking up a patient, and when we finish, take off our gloves, discard them, and you have the choice of using hand sanitizer or wash your hands. It's encouraged to wash your hands, but given the time and time constraints and just the environment of the outpatient unit during changeover, during these sensitive times when you're taking off and putting on, a lot of the staff members go for the hand sanitizer opposed to washing your hands. So all this is very important to reduce the risk in the transmission of infection, and is properly called infection control. And even now with the pandemic, it has become the utmost importance to be mindful of your infection control protocols and what one is doing.
Okay. Steve, today's my first day of dialysis. I've never done this before. Tell me a little bit about what I can expect on the first day of dialysis. What's going to happen to me as a patient?
So what's going to happen once you walk through those doors, you're going to be greeted if a secretary, which is normally called a unit secretary or admin secretary, administrative assistant, they're going to welcome you in, and then they're going to give you the paperwork, or some places may have the AA talk to you, or the social worker or the nurse. Somebody's going to go over that paperwork with you. And the paperwork that I'm referring to is the admission package. And the admission package has the lab benefits to pay the labs. They have advanced directives. They have the consent form. They have the patient rights, responsibilities. They have hepatitis B consent form, and just some other necessary paperwork that goes along with this process. And once you fill that out, right, once that process is finished, then the charge nurse or whoever's taking care of you, whoever's assigned to you, that technician, will tell them that Mr. So-and-so is ready. So once the patient signs that consent form, because that's what they're waiting for them to sign that consent form, call them back, let them know the process, come on over here, this is where you weigh. And a lot of times the patient has a catheter. 95% of the time the patient has a catheter, unless the doctor had already set this up and they had a access placed in long before dialysis initiated. But the majority of the time, patient has a catheter. So if they didn't, they had access in the arm, we would tell them, show them where the sink is to wash their access. Then have them to go away, tell them this is the process. Each day you come in, we need to get your pre-weight. You need to take everything off. If you got on heavy boots, take them off, but pretty much remove your coat and the items in your pocket, get your weight. Once you get your weight, pretty much we already introduced them to the technician, take them back to the chair. And like I said, a lot of patients come from the hospital with these catheters, so they already know the dialysis process. They just don't know what happens on an outpatient basis. And so they come in, get the weight, go to the chair, stand up, get their pre-blood pressure, get their temperature, sit down, blood pressure, temperature, which we call vital signs. Then the technician does what they do, get the weight, and we let them know how much to pull off. Normally that's already pre-planned, how much to remove, how many hours they are. So all that's programmed in, and then they got the pack and everything made. And so then they're right there cleaning the catheter, getting access to it, making sure it works with the syringes, and they initiate dialysis. And the patient, normally a lot of places give patients a welcome bag that may have some earphones, a blanket. They sit in the chair, and pretty much what I do, I can't speak for everybody, but if I was not the charge nurse, and if it was my patient, I was working with that patient directly, then I'll let them know about the TV, just get them comfortable, ask them how they feeling, are you doing okay? Set the machine to take the blood pressure every 30 minutes, see what medications that were ordered. They may be ordered a calcium med or iron epogen for the anemia, whatever. They may even be on an antibiotic. Go and get that ready, let them know what's happening. And I mean, that's pretty much it. And then they go through the treatment, return the blood, sitting blood pressure, standing. Of course, the nurses do the assessment, pre and post assessment, check lung sounds, heart sounds, checking for edema, making sure everything went okay with the treatment. And once they finish, we take them back to the scale to see how much fluid was actually removed. And we tell them we see them. If it's a Monday, we tell them we see them Wednesday at the same time. If it's Tuesday, we tell them we see them Thursday at the same time. And then that's the start of that new normal. And unfortunately, Uncle Jim, this has nothing to do with the first day, but for a lot of patients, they're in the hospital, they have jobs. And when this happens, they lose their job because they don't know about the home dialysis options. And so being that they're not told about it, you know, they'll go outpatient and go to work. And then, you know, they may get sick, you know, start missing days at work. And then that whole process starts where, you know, if they, you know, they may have to stop working because it's too much on them. Whereas if they know about home dialysis and get that longer treatment and not have to rearrange their schedule and work on their own schedule, then that may not would have happened. I've seen that many times as well.
Yeah. Very good. I'm glad you brought that up. Let's talk a little bit about what happens at the end of treatment. What can the patient expect when the 3 or 4 hours is up? What happens then?
Well, once the 3 or 4 hours is up, I mean, you pretty much return the blood. The machine goes off. We put it in pause. We reduce the blood flow rate, and we start the process of returning the blood. We call it rinse back. We rinse back the patient and finish up, you know, the treatment. You know, however, there's many things that can occur during that process. Again, the patient can become symptomatic so with some patients, once we start the process of rinsing their blood back, some patients have a tendency to sit upright in their chair kind of fast. And when they do that, their blood pressure bottoms out or it drops and they'll pass out sitting up in the chair. And then we have to put them back in what we call Trendelenburg position, where the chair is back where the head is lower to the floor. So that way the blood will rush more back to the heart and bring the patient back around. But that's normally the process. We return the blood. There's a process to everything, to start dialysis and to discontinue. And you do that process, return the blood. If they got a catheter, you clean it, the cap, and you cap it all, put the caps on it. And what I mean, like right here, where you had these caps right here, once you disconnect the line, you clean the hub of this catheter with alcohol or whatever, and then you put brand new caps on it, and then you may cover it up with a 4x4. If a patient has access in their arm, a fistula or graft, we remove the needle and use 3x3 or 4x4 gauze, fold it up and put direct pressure on. Either the patient hold it or we put a clamp on it until the bleeding stops, and then we tape them up and they're on their way. Unfortunately, with some patients having the graft or the fistula in their arm, some patients have drove away from the facility and started bleeding in the car and had to turn around to come back because their whole sleeve inside their arm was soaked with blood.
Yeah. I used to go through that, Steve. they'd have me sit down and take my blood pressure at the end, and then they'd have me stand up. And many times when I stood up, I start to bleed right through the gauze. So you'd have to new dressing, hold it a little longer, sit still until it stopped. They were always seemed to be really concerned about not letting me go until the bleeding stopped. That was a big issue.
Oh, absolutely. Absolutely. I've known patients that bled out at home that died.
Ouch. Ouch. Okay. Do you have, as a patient, certain rights as a hemodialysis patient? And if you do, can you talk to us a little bit about that?
Absolutely.
You okay,
patients,
buddy?
Yeah, I'm okay.
Okay.
Thank you. Yeah. Patients, whether they know it or not, have rights. We all have rights when it comes to medical procedures or anything that deals with medical. When it comes to hemodialysis or outpatient hemodialysis, it's no difference. You have what's called patients' rights and responsibilities. So that's a twofold. Patients have rights, and then they also have responsibilities as a patient. Now, there's a lot of rights that patients have, and very honestly, I don't know all of them. But however, I do know each place have standard rights, or actually from CMS, they have standard rights and responsibilities that all patients should have. And some of them rights, you have a right to your treatment options. That's a right. You have a right to be involved in your medical care. You have a right to dignity, respect as a patient. You have a right to access to your medical records. And like I said, there's a lot of rights that a lot of patients aren't familiar with. And I encourage them, if you're watching this and you didn't know this, to go back to your admission packet, if you still have it, when you first started dialysis, and you should have a copy of that. And it tells you your rights. You have a right to be involved in your care. So if the doctor, for instance, if the doctor says they want you to run 4 hours and you think you'll do better at 3.5, you have that right to interject and tell them that. You have the right, if you want to discontinue dialysis, you have that right as a patient to discontinue dialysis, regardless of what anyone else says. If you're in your right sound mind and you've been on dialysis 5, 10, 15 years, and you decided that you didn't want to do it no more, that's another treatment option that a lot of patients aren't aware of. I'm not encouraging that, but when you talk about kidney dialysis, outpatient dialysis, transplant, or anything that deals with kidney disease, you got to tell the whole truth and nothing but the truth. That means you got to tell the good as well as the bad. And so, with that being said, you have to know everything.
Okay. I just wanted to point out to our audience, the book talks about whether or not dialysis is a cure. Is dialysis a cure for?
No, dialysis is a treatment option. And so, just like I just mentioned, if a patient decided to stop dialysis, that's another treatment option. I mean, there's no secret that there's no cure for kidney disease. Okay. And again, transplant is a treatment option. It's not a cure. It's just another form of treatment. And so you have patients who may not decide to do the transplant treatment option. And that's okay, because they may feel good with the treatment option that they're at. They may feel in control of being at home, doing 6 hours during the night, feeling fabulous, not on any medicine, because research has shown, and I've seen it with my eyes when I work with nocturnal patients who've done 6 to 8 hours, that they were taken off of all their medicines after a period of time. All the hypertension medicine, the calcium, all that, maybe one medicine. Okay. So maybe that may be the option for them, and they're okay with doing the rest of their life on hemodialysis. Again, people with transplant, yes, that has been shown for people to may have a better lifestyle, but who determines that? And who determines that when you have patients that on dialysis that have the same clearance as a patient that has a kidney transplant, and then that patient, they have the same they have the same clearances, getting the same quality from their treatment, but the patient on doing hemodialysis may not be on any meds, and the patient that had the kidney transplant may be on 4, 6, 7, 8, 9, 10 meds that have to experience the side effects of long-term steroid use or other antiviral use that they may have to. So when you do these treatment options, and that's why I wrote the book, you have to look at what treatment is best for you. Okay. Transplant may not be for everyone. And if it's not, other warriors should not chastise or criticize or throw shade on someone who decides not to have a kidney transplant but wants to do dialysis at home or in center, and vice versa. If someone decides to get a transplant, I don't think people who may have went through that process and may have had a negative experience, throw shade on people who may want to go with that option. There's no right or wrong option. It's what's the best option for you at the time that you experience this unfortunate situation.
Okay, I've had you on the heater now for about an hour.
Sure.
And we haven't near scratched the surface of that great book. I do want to make one statement. I want to tell our audience something. My friend, my good friend, Steve Belcher, is such a teacher and an educator that he insisted, because I gave him an out. I told him, you don't have to do this, Steve. I'm coming out and talking to us tonight to tell us these things about hemodialysis and about some of the ins and outs. And please take my word for it. This is a terrific book. You should check this book out. I think we all know that Steve's father passed today. Okay? And I just want to say condolences to you, Steve, my friend, and condolences to your family. But I wanted to let everybody know what a real and true kidney warrior you really are, and how much we greatly appreciate everything, and I do mean everything, that you do for us. All of the shows that you produce, all of the on-the-spot interviews that you do, the petitions that you prepared. I just want you to know, Steve, your Uncle Jim loves you. We all love you. Thank you so much for taking time to talk to us tonight. You're the best, buddy. There's nobody that's any better.
Well, thanks, Uncle Jim. You know, this morning I woke up and saw that Shayla McMillan passed away, who was on our show. And, you know, I was thinking back memories when she got a transplant, when she was supposed to be on our show. She got called and the mom reached out to me 3 a.m. Little did I know that I would, you know, wake up, get up out of bed, hour later, take a shower, and my mom calling me, asking me to go check on my dad and finding my dad deceased. I'm fortunate as that is, and being that I'm at peace with myself and at peace with my dad's death. He lived to be 90 years old. And like I said, this was unexpected. However, even though my dad passed, kidney disease is still going to be there. People, next year at this time, people are still going to be diagnosed. People are being diagnosed as we have this conversation right now. Somewhere in the world, someone's in a hospital undergoing acute dialysis. I don't know where, but somewhere in this world, somebody is being dialyzed as we speak. And so, even though I really, and I want to just say this, I really appreciate the outpouring of love. As I mentioned earlier, I've seen a lot of kidney warriors die throughout my career. I've seen people's families cold in the hospital, done CPR, you know, and I always thank God that I had my parents after these episodes, and always dreaded that this day. And the only thing I can say is that this last year and a half that I lived with my parents as an adult, as a result of my injury and having to sell my house, that, you know, all things work in accordance to God. And I was able to enjoy and spend the last year and a half with my dad than I have throughout my adult life. So, and just want to say to this guy, Robert Shannon, and a lot of the people in this group that I'm in, that's not a kidney group, but it's a Facebook group that spurned out of a bad situation that some would consider was racism. But out of this ugly situation, a group developed, and I don't know none of these people in the group. And, you know, I mentioned way before that I have trust issues, and I'm not normally trying to be outgoing, but I've tried to be outgoing to let people know what I'm doing with this movement. But for these people in this group, it's called a Misfits group. You know, don't let the name fool you because it's called Misfits. But for these people in this group that I don't know, I never even met them, maybe one person, two persons out of that group behind this protest, but to receive the love from these guys, you know, it helps the process much better. To receive love from the kidney community and the outpouring of love, it just helps this process go much smoother, you know. And now I know how I feel. I mean, I lost my sister in 2009, but there's nothing compared to losing a parent that, you know, raised you and was there for you throughout your childhood and even, you know, through this process now. And I was just so fortunate that my dad was able to see me, you know, write a book, because as I mentioned, I wasn't the best kid growing up, and we all have a history. And I was just fortunate that I was able to accomplish some of the things that I accomplished, and that my dad was able to see that before he left this planet.
Well, I just wanted to say, Steve, we in the kidney community, we just want to say thank you. And we want you to know that we appreciate you. And on a personal note, your old Uncle Jim appreciates you giving him a chance to be on your network. And I just wanted to say, you know, I love you, brother. And I really, really respect the things that you try to do for us. And I just want to say thank you, Steve.
All right. Thanks, Uncle Jim. Thanks, because it's, you know, again, with kidney disease being the 9th leading cause of death and affecting majority of minorities, but everybody's impacted. And for so many people to be affected by this disease, and there's still no cure or no mainstream mention of it until you hear stories of a transplant or something miraculously that deals with a transplant, is only when you you know, get attention. So I'm just trying to change that narrative, you know, when it comes to this disease and how it affects the minority community. Again, a lot of people haven't walked in my shoes, and when I say that, Uncle Jim, I mean, again, you know, you asked me about the book. I mean, I know I gave you, you know, I said about the education, but it's really more to it than the education. It comes from 33 years of experience and seeing patients who get diagnosed. They go to the hospital, through the ER. They don't know what's wrong with them. They can't breathe, respiratory distress, fluid in their ankles, whatever, blood pressure 220 over 130, whatever the case is. And then for the doctor to come back in after they draw blood work and be told that your kidneys aren't working, that you're going to have to start dialysis. And then when I get the call at 2-3 in the morning and get up and go in and bring the dialysis machine to the patient's room 2 and 3 in the morning, they're waiting for me to get there. And it's pretty much like race against the clock, pretty much. And so I go set up. And when you see these patients and they have the breathing mask on and they can't really catch their breath because they're in respiratory distress, you know, some actually get intubated where they get the tube in their mouth. But you know, when that happens and I get into the room and the patient's looking at me, asking me what's wrong, and you see their eyes and they got tears streaming down and they don't know what is going on, it's heart-wrenching. It really is. It really is.
Well, that's why we count on you, Steve, because of your experience and the things that you've seen and the things that you're willing to share and the big heart that you have for all of us. And you know, people should know you're what, a stage 1 patient, right? Stage 1
Yeah.
patient,
Oh,
something like
and
that.
speaking of that, one thing I didn't share and why I advocate so hard as well. Yes, I do have stage 1 kidney disease. And my dad has stage 3 kidney disease. He didn't pass away from kidney disease, but he has stage 3, his GFR. We did a phone.
We got you, buddy.
We did a phone consult last week with the nephrologist, and his GFR was at 30. And him being at 90, I let the nephrologist know. I mean, they wasn't trying to go more toward dialysis, but they was just didn't want the kidney to be squeezing too much. They didn't know he was getting dehydrated. But my dad had stage 3, and so that's why I didn't share that. But I go hard too, and I made sure that he wasn't going to do dialysis if it would have came to that. And if he would have said he wanted to do it, it would have been at home. But it didn't resort to that. But he did. He had kidney disease, and that's why I kind of went as hard as I did, because he fell victim to it as well.
Yeah. Yeah, well, I know what that's like, Steve. I lost my dad to PKD and congestive heart failure, renal uremic poisoning in 1983. So, and I will tell you, I think about him every single day, and I miss him every single day. And he has been a large part of my inspiration for the kidney advocacy that I do. And I am hopeful that, in your own words, that you will turn this into a positive thing, that you'll continue to contribute to the kidney community. And again, you're a real mensch for coming on tonight and talking to all of us. And I can't tell you how much all of us in the kidney community really, really appreciate you, baby.
Yeah, I appreciate that, Uncle Jim. I mean, again, like I said, as unfortunate as thanks to Lee, thank you, Gene. As unfortunate it is, again, there's many people across the world right now that maybe died. Like I said, Shayla McMillan lost her life today. Mm-hmm. She was a kidney warrior. And so, her and my dad and many other people lost their life today. So, again, I just, appreciate the outpour, because honestly, that's what helps me get through this.
All right. Well, buddy, I'm gonna let you go, okay? And thank you again for taking time to teach us, as always. And plenty of comments for you to review to this broadcast. And I promise you, your Uncle Jim's going to pass this around a little bit. You know how I am. So we will definitely.
I just want to just share one thing before I go. Tomorrow is going to be the start of the first of a 3-part series sponsored by Outset Medical Card, At Home with Outset. And this is a home dialysis show, as I said, sponsored by Outset Medical, makers of the Tablo dialysis system, which is used for home hemodialysis. And the host of this show will be Tracy Amadi, who was the first patient to perform home hemodialysis using the Tablo dialysis system in the United States when it was approved by the FDA last March. And the show starts tomorrow at 6 p.m. Eastern Standard Time. I'll be producing the show, and it's geared toward focus on home dialysis. The first part will share Tracy's story and her experience with transplant. And then the second show will pretty much go over some of the benefits and advantages of home dialysis. And then the third show, which are a month apart, each show. So the first show is tomorrow. Then the next show would be a month from tomorrow. We don't have the exact date, but it's one show each month. And it all centers around home hemodialysis and putting more emphasis and education and focus on home hemo. And we understand that a lot of, not all patients are going to be able to do home hemo. However, patients that are able to and that would benefit from it should be aware about this show and know that this option do exist, and that there has been lifting of constraints that may have in the past prevented patients from going home. So we look forward to partnering with Outset with this new show, this 3-part series show, At Home with Outset, and hope that it will benefit patients who are considering or thinking about doing home therapy, whether it's CAPD, CCPD, or home hemo, just to know that they have that other option at their fingertips.
Wonderful. Wonderful. We'll be sure to check that out. Steve, sounds very, very interesting. Thank you for bringing that to us. Okay, we're going to wind it up now. Show's coming up. Dawn Kwiatkowski's going to come talk to us. Chris Hernandez is going to come talk to us, tell us her story. The cooking doc and his friend, the plant-based doctor, are coming back to see us real soon. The one guy's going to talk to us about eating vegetables, and the other doc is going to make some recipes for it. So we'll see you all soon.
Out.
All right.
All right. Thank you. I appreciate it, and thank you again, everyone, for the love and for the love and support, outpouring of support. God bless everyone. Thank you.
Take care. Good night, everyone. We'll see you soon.